just meet you all. I'm doing my best to try to remember names, so bear with me. I know even if I meet you a couple times and the light's not on, I will get your name, I promise.
Higher standards,
Okay.
man. We remembered yours.
One guy versus 100. But anyway, so I wanted to really take this time to go over some different things, mainly procedures that I'll be doing here in the ICU specifically, and try to get everyone comfortable with the system on how I do things. And again, I know it'll be a big learning process. First thing I wanted to discuss was the bronchoscope. I think doing bedside bronch BALs was a little new last week. So I wanted to kind of discuss that. As far as bedside bronch BAL, I'm very comfortable doing them, routine doing them. It's a common procedure that I do a lot of times when someone's intubated for hypoxemic respiratory failure. If they have any junk consolidation on their chest x-ray or chest CT that I see, or I think we just need more data on BAL samples, then I'm more aggressive on doing a BAL. And I like to do it usually right after I intubate. They're already paralyzed and it's just a lot easier, and it's usually a very smooth process of taking a quick look, doing a quick sample right after I intubate. And thankfully the GlideScope is prepared to do all of those things for me as an intubate, as well as do a bronchoscopy, a quick one. So in general, let's say I was planning on intubating bronch, you might see me or hear me fumble those two words right after the other, because in my head, if I'm thinking, okay, blah, 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 I'm gonna intubate and then I'm gonna bronch. It's just, that's how it goes with me. Bronchoscopy for me is as simple as, it's just my bread and butter thing, just like a nurse putting in an IV or whatever. It's something I'm very, very comfortable with. So I know not everyone is as comfortable, but hopefully together we all will, after some time, get comfortable doing these things together. In general, after I intubate someone, I like them, so to do a bronchoscopy, I expect with time, it can be just the resources we have here. I don't think endoscopy needs to come up and do it. I think they will be reserved for my more advanced procedures down in eventually the endoscopy suite, but right now the ORs, where I'm doing EBUS, biopsies, and eventually next month, hopefully starting with our first robotic bronchoscopy cases, which is really exciting. If you guys haven't heard about that, we're getting that next month. But for simple bronchs and BALs, or if a patient is bleeding and I'm wanting to do an airway exam, up here, whatever staff RT as well as nursing bedside and the GlideScope, these flexible bronchoscopes is what I'll be using. So I like the patient to be on the ventilator for this. There is an adapter that we will make sure I will get with endoscopy with Stacy. There's a little adapter. Some of y'all who did it with me last week were able to see that, but it's a little three-way adapter that just goes right on the ET tube, and then the ventilator connects to it, and then there's a little port on top for me to stick the bronchoscope through.
Swivel, we have it in the main Pyxis
Okay,
area.
We have
perfect.
those.
All right, yeah. So I would want to hook the patient up to the ventilator and then put that adapter on. And then I would use this GlideScope, flexible bronchoscope, and it plugs in just like this, the same screen and everything. I would want lubricant on the end of this, about 3/4 of the way, all the way down, suction attached to it. And then if I'm likely doing a BAL, which 99.9% of the time I will be, a trap. Okay, a trap. Is everyone familiar when I say trap?
Yeah.
Okay. A trap, as well as several of these slip tip 60 ml syringes with normal saline in it. Okay. If I expect bleeding, I would at least prep whoever I'm doing it with beforehand. We'd have a game plan before we went in, but I would want this like chilled and things like that. But In general, just normal room temperature, normal saline from those big, large bottles will work. Right there.
I have a list.
On the ventilator, specifically for RTs, when I'm doing a bronch, as you guys all know, but set the pressure support alarm as high as it'll go because I'm going to be causing increased peak pressures. I'm also going to be suctioning out the volumes, so they're not going to be getting good volumes while I'm doing the bronch BAL. I like them to be on continuous monitoring, ideally, and we'll find a way. I like to be able to hear the pleth on here, like do you guys know what I'm talking about? I can see a nod, yes. I like to be able to hear that while I'm doing the bronch. Just, I'm used to that. It makes me feel comfortable. It's like my little special happy place when I'm doing a bronch. So, I like to do that. I want blood pressure cycling every 1 to 3 minutes while I'm doing that. And then the procedure itself, once we're actually set up and I'm doing it, very quick. I usually do it in like 2 minutes, if that, and then come out, and that's pretty much it. Send the bronch BAL sample for the lab. I still am working with Tony to talk to the lab about what I'm ordering with the special things, but that I don't think that's pertinent to you all here. Just know that I'm working on getting the right things sent so we can put the labels on and get it sent to the lab for the right things that I want done. First off, I'm gonna pause. Any questions related to bronch BAL here at the bedside
How
using
many
the
60
Bronchoscope?
ml syringes do you want?
3 or 4. Yeah.
We also don't stock 60 mil slip tip syringes in the hospital. They're 50 mils.
Or 50
That
mils, sorry.
60 just happened to be one left over that Indo found this morning, just so everyone can see what the slip tip looks like, because there's some confusion on the slip tip versus the oral syringe. We're probably gonna be stocking 50 mils, but I'll get with Michaela and there'll be a list that will go out so everyone knows.
And we don't have these up here in our unit, so if he's up here doing a procedure, we'll have to get out without surgery. Until we can get them stocked in our business.
Any other questions about bronch? How does everyone feel about bedside bronch? Me doing it.
Where would we put chilled fluid for?
So this, you would chill this, just in a gray tub with ice even works. Don't open it,
Okay, so
just set
not
it
a
in there.
certain temperature chilled.
No,
Yeah.
so just gray tub, ice in it, and just stick that in there. Yeah. Okay. Good. Well, I'm available for questions as far as that, and anytime if you guys have questions, just let me know.
Sorry. Just a quick thought.
Yeah.
So I'm used to filling up the syringes, sticking the syringes in ice. You want us to put the
We can do that as
sterile
well.
water? Oh,
We can do, not sterile water, no one say
yeah, saline,
Yeah,
sorry.
we can do that as well.
Okay.
Either one, just as long as it's submerged in cold ice water. Whether it's, if you wanna stick that whole thing in there, that's fine. If you want to draw up the syringes and then stick the syringes in there with the tip up, that's fine as well. Okay?
Do you have medication preferences? I know it
And
can change, but some people just prefer a certain cocktail.
sure. When I'm intubating, and most of the time when I bronch, it'll be a lot of times right after I intubate. In general, I like Versed fentanyl, etomidate, and rocuronium. That's most what I'm comfortable with. You'll notice, and especially the nurses over the weekend and things like that, I will always ask for likely more than what I will use. I like to be prepared, so in case I need it. But I usually do paralyze for most of my patients. And then that sedation and paralytic will carry me on into the next procedure that I'm doing as well. If someone's already been intubated and they're on general sedation, I usually don't need anything else unless they're a severe ARDS patient with high pressures and things like that. And we would kind of approach that a lot more cautiously. I would sit down with whoever's gonna be doing it before. I wouldn't just roll in and be like, let's do this. I would kind of have more of a game plan of, chances of a pneumothorax are really high, pressure's really high, it's gonna desaturate, I'm gonna paralyze and things like that. But I like everyone to have at least a game plan. These are just like general BAL, like simple, easy. That's just general routine things. But if I foresee, and I'm usually pretty decent about foreseeing if something's going to be complicated or not, I'll sit down with whoever's involved on that case, and make sure that we're all on the same page.
Do you have a particular mode you want the men in during the bronc? Do you don't care?
ACVC, lower PEEP 5, and then just a high
Alarm.
pressure alarm,
Okay.
yeah. 100% FiO2. So, okay. Bronc, good? Alright, good. And I am going to speak to the OR staff and see about, I would like an endobronchial blocker up here, just in case, as well as a Fogarty catheter. So for those that don't know what those two things are, if a section of the lung is hemorrhaging, and I don't really know what the bleed is from, I can go down there with this, I can start suctioning, and I can identify at least where in general vicinity that bleed is coming from. Isolate that, and I can tamponade it with balloon. The Fogarty catheter allows me to get distal into the more subsegmental bronchi and occlude certain lobes. The endobronchial blocker will allow me to like jail off an entire lung and things like that. So hopefully we don't run into those too often, but you know, massive bleeding, it could happen. So risks associated with a normal bronchial, it's a very low risk procedure. Things could be, the biggest ones will be during monitoring, hypoxemia. Like I said, I'm suctioning a lot of the volume that the vent's trying to give, so they're not gonna be getting that. They're gonna desaturate. If I usually don't freak out, so if I'm not freaking out, there's no need to freak out. And I don't freak out. So if they get hypoxemic during it, I'll just come out and we'll just rest a while. But in general, you can expect that. Also, if they have horrible lungs and I'm intubating them for that reason and I go down to bronch them and do a fluid sample, expect they're gonna be hypoxic for another 4 hours after that, right? It's not gonna, I'm not gonna do a bronch and it's gonna get better. It's actually gonna get a little worse for a little bit of time. Unless it's like I'm doing a suction, purely suction bronch, and they had a bunch of goobers down in their lungs and I sucked them out and now they got a lot better. But in general, their oxygenation is going to be a little bit worse right after that. It's expected. There might be a little bit of bleeding. I don't think I'll ever be doing a biopsy here in the ICU, ever. So the chances of bleeding are really low. If they have really inflamed mucosa and just me going in is inflaming the mucosa by just bumping up against it, there might be a little bit of blood tinged sputum, but that honestly is about the same as us being overly aggressive with suctioning while they're on the ventilator. It can cause, you know, bloody secretions. If you're ever getting more than 50 mLs, 100 mLs, 200 mLs of bright red blood, let me know. If I'm not around, we've been talking with Jackie and Tony as well, but I'm not currently on emergent. You can let the primary hospitalist know and they can call me and I will be around. That process is still a working process. It's above my pay grade, so, but stay tuned. Okay, that's the big things I think from the airway. Anything else?
Would we ever do any like brushings or anything up
Not
here?
really. I mean, on the off chance, but that would be really like maybe one this whole next year. I'm not usually going to be doing any diagnostic of that type of stuff. It's just BAL samples, and I'm wanting to see 99% of it's going to be for infectious reasons and or like inflammatory if I think it's like an organizing pneumonia, or I'm wanting to see just the fluid studies and the cell count differential. But I'm not, if someone has like an endobronchial mass, I'm not going to be biopsying it here. I'm not going to be doing any of that. Okay. I would like to do that more in the OR for the next year. Okay. All right. Other things, procedures that I'm going to be doing that I think everyone seems comfortable with so far, but we grab things. So first off, for all procedures, I like to do, in general, I like to do my informed consent. If informed consent is something that I think is really important, conversation. It's not just a me telling a patient, but an actual conversation where they understand everything that I'm doing, and have a good, clear-cut reason for why I'm doing it. In general, if someone is able to get the consent for me, that is okay. Just know that I will still do my best, at least if they're here, to have a full conversation about the procedure before I'm doing it. So I take that part on my own. Whether the signing of the form is me right there with the patient or done before I'm in there, the conversation part is going to happen from me. I'm the one doing the procedure. So in general, you should really only be getting consent if you were the one doing the procedure. I'm a big stickler, as we all should be, on sterile precautions for any type of procedures. No matter how big, no matter how small, they're all sterile. And so hat, mask, bouffant mask, gown, gloves, all that stuff. Whoever's in the room needs to have a bouffant and a mask on, okay? And in general, like if the patient's awake and stuff like that and they're not in a closed circuit, I like for them to wear a mask as well. So that kind of gets me into all the procedures that I'll be doing. Arterial lines, I use different ones. These are the radial, but in general for radial, I like the arrows, the long arrows, okay? And then these are the femoral art line kits. I've not used it yet, so stay tuned. I think I'm gonna do my first one over there. But it's just this general kit. For central lines, I don't like the ones that we have currently in use right up here. There's no flushes inside of the kit, and so I think sterility is impossible to be maintained, unfortunately, the way they are now with those kits, because actually putting on the PRN caps, which is what I call the little blue, yeah, I call these PRN caps. I don't know what everyone else calls them. That's what I'm saying when I say PRN caps. These are not in the kit, and which is fine. They're not supposed to be. They don't have to be in the kit, but the flushes are not in the kit as well. So afterwards, when I was using these kits, I was having to like flush it and everything like that. It just increases the chance of infection, which is what we're trying to avoid when we're doing this central line.
We used to have sterile flushes. Do we not have them anymore?
Those are very expensive. The ones that are, I just know, I've been told my whole life of training that those are extremely expensive. I used, Brady went and got a kit from the ER yesterday. That kit had the flushes in it, and I liked that kit a lot better. Other things, central line, art lines, thoracentesis, chest tubes. Thoracentesis is just the regular thoracentesis kit right here. It's the same one I use for a parakit. This one has enough lidocaine in it, so I won't ask for lidocaine in addition to it. And the chest tube though, so I'll do two different kinds. I don't think we have one here. So I will do, most of the time I'll do what's called a pigtail catheter. It's a smaller bore chest tube, usually around 12 to 14 French. And that is actually using Seldinger technique. We have them in these kits. That is doing a needle and doing Seldinger technique to put the catheter in. It's like essentially when I'm describing it to a resident or an intern, it's a central line for the chest. It's the same thing. And I also occasionally will do surgical chest tubes as well, depending on what the etiology is. The data, just FYI, is really trying to push that pigtails are just as capable as surgical in most cases, including, I still do surgical and hemothorax, but even hemothorax, pigtails are just as effective as the smaller bore chest tubes. We just have to flush them more periodically. And on the chest tube, when it's attached to the atrium, which is this, is everyone comfortable with the atrium, setting it up and everything like that? Good. You open it up, it's pretty simple. You put the fluid in, and whenever it's set up, if it's not on suction, the little orange accordion will be off to the side. As soon as you put it on suction, the orange accordion will come over and you can see it. So that way you can kind of look at that and see that it's on suction or not. I will set, and you can set the amount of suction on the atrium itself. It'll be 0, -20, -40 centimeters of water. And then you just attach the tubing to the wall suction. So as long as the wall suction is on continuously, then it doesn't really matter what that is set at. It's being controlled at this junction right here. Does that all make sense?
Do you have a preference, a pressure?
No, it depends on what it is, if it's fluid versus air versus whatever I'm draining. So I'll kind of judge that on case by case. And I'll usually, whoever is in it, the nurse, I'll just go, hey, let's keep it at -20, -40 suction over the next 24 hours. And I may do, and I will do my best. Tony is really helping me with this. So we'll put in nursing orders on what to do after I put it in, like, drain for 2 liters and then clamp it or whatever. And then I can also help when I talk about clamping. It's a 3-way stopcock. And I like these PRN caps to be on the end of it as well. And then you just put this is a small bore pigtail chest tube kit. Sure.
Doesn't have the PRN cap in the kit.
Yeah,
He likes to put on
after.
with the stopcock.
Yeah. And I'll also, with these, I'll also ask for lidocaine 1% with epi in addition to this, because this one does not come with enough lidocaine in the kit. So, flushing, is everyone familiar with flushing of a chest tube? Who are gonna be flushing a chest tube? No, okay. So we can go over that as well. So when the atrium is on, and I'll show you, we could probably
You
set
can
one
open
up,
an
but,
atrium if you want to.
yeah.
If you want to show.
Well, no, because it would be meaning to open up a chest tube kit too. But let's just do that. That'll make it easier so everyone can see.
That's your, that's working.
Okay. So. This is the pigtail chest tube kit, the one I'll be using the most. Obviously, I would be sterile, everyone would be sterile. It's got everything I need in there, chlor prep, dressing, and just so everyone kind of knows what it is and why I say it's kind of like a chest tube. After I've lidocained them up and done them up, I go in with a needle attached to a syringe, and I use negative pressure, and I go in just above the rib until I get fluid. I remove the syringe, I take my wire, and I feed that through until the wire's in there. After that, I remove the needle. I make an incision in the sub-Q tissue, and then I will dilate that tract over the wire into the pleural space, and then I will enter the catheter into the pleural space, and I'll leave about usually that much left, so it kind of stops at the skin right there or so, and then I suture that in place, and then I'll put a dressing on there. There's no dressing on this, so a Tegaderm or something, just nice and clear, because I like to be able to see it nice and clear overwards as a dressing, and then I'll leave that in there, and then this attaches to this cord that comes in the kit. And then after that, while I'm doing that, you can be getting this set up and ready. here, so the little swivel at the bottom, okay, so it doesn't knock over, just like that. There's fluid right here and a little syringe on the side. Take that out. And then where the suction is going to be hooked up, that's where you put in the fluid. And you see it going down there into the water chamber. Okay. And then right in here, this just lifts up. This part has a sterile cap on it. And in general, you just kind of hand it out to me like this. I'll take that off. And I will attach it to here, right here. And just realized this is different from what I'm used to, so this is good. I'm glad we did this. There's no three-way stopcock in this chest tube kit. So we will need, yes there is actually, it came off. There is one in the kit, okay? All right. So this is how it is. The chest tube is in, it's inside the patient, I've sutured it, there's a sterile dressing, and it's kind of like this. I will leave this out. I like a PRN cap on the edge of it. Just like this. And then I will usually tape it on the patient to where pressure is, there's a little bit of slack, so that way, like when they're moving around and things like that, I try to avoid being pulled out. Invariably, accidents do happen, and it happens, and that's not the end of the world. Okay, daily flushing. So it's like this. It's like the patient. For flushing, does anyone have a flush? In general, I don't need to do it, but in general, so for a three-way stopcock, I'm sure you guys are all aware, but wherever this is off to, that's where it's off. So right now it's off to here, and it's open between the patient and the atrium, which is where I will want it when I say keep the chest tube open, okay? Whenever you're flushing it, what I like to do is a normal flush. I close it to the atrium first. I use an alcohol pad to clean this, and then I will inject the flush fully into the patient, so into the pleural space, and then that same that I just did, I back it, I suction back about the same amount or roughly some fluid, and then I close it to the patient, and then I go back that way. So the big point of that, just common sense, is I'm just trying to keep this catheter open and flush. That's it, so it doesn't clot and drain. And then once I'm done flushing it, then I close it again to here, so it's left open to drain again. If I ever say clamp the chest tube, that means just this three-way stopcock, I close it to the patient. Okay? What questions do you have for that?
Orange cap on your stopcock when you're not.
Oh yeah, when I'm done with this, the same orange caps that you put on there, put on that.
Pain to the patient?
Just right there. When
No,
it's,
sorry, pain that the patient experiences with flushing?
no, in general, no. They might experience a little bit of discomfort. So, in general, the lungs do not have pain receptors. The pleura, though, definitely do. So, there might be they might feel that flushing. Shouldn't be any pain. They shouldn't go, ow, ow, anything like that. If something like that occurs, let me know, notify me. But that in general should not really occur with a simple flushing. Now later on down the line, when I'm doing things for intrapleuralytics and intrapleural thrombotics like TPA and Dornase, those things do hurt. And in general, I like to pre-medicate the patient with fentanyl. I like to inject lidocaine before I put this in here, and then I inject the medication, and I keep the medication in there and it clamps for about an hour before I release it. They will experience pain with that, but in general, flushes shouldn't experience too much pain. They may notice it, they may feel it, but it should not be a, ow, that hurts. So,
Thank you.
yeah. What other questions? Blood in the chest tube is fine. In general, it'll probably be right after I place it, so I'll see it, but yeah, that's nothing too big. Now, if it's just hemorrhaging blood and stuff, let me know, and we'll go from there, but in general, blood, you would expect serosanguinous, even to sanguinous blood sometimes. I do my best to avoid all the veins when I put the chest tube in, but in older folks, they can become, the vessels can become tortuous with time and kind of droopy, so.
Is there any air expected from the pigtail versus a large bore? I mean, more in the atrium. Are you gonna get more bubbles with the pigtail than you would?
It depends. It depends on what I'm treating the patient for. So if someone had a pneumothorax and I put a chest tube in, then I'll be monitoring an air leak. And how you can tell if there is an air leak, what she was saying is the water here will be bubbling. Okay, it may be, and you can grade that based on, is it a continuous bubble? Is it only when they're expiring? Is it only when they're coughing? And you can grade it, but to see how bad the air leak is. But in general, expecting a little bit of air there is fine. And remember that, like in my process of putting the tube in, even if there was no air before, there may be a little bit of air that'll just come out, and that's fine. So, any other questions?
Does the amount we flush with depend patient to patient, or is it just a 10 mil?
10 to 20. It depends on, there is no set, just keeping it paid. If you want to do 2 flushes every time, then that can be 2 flushes every time. It's kind of whatever you want to do, whatever you have time for. But in general, the big thing is just keeping the thing open. So more frequent flushing. I like chest tubes to be flushed at least twice a day. And just, if you guys do it, like morning and like the start of each shift or the end of each shift, whatever is comfortable, and then I come in and I usually flush, it's just my routine, while I'm in there, and the chances of them staying patent is a lot higher. So, it's never a bad thing to flush it. If you're ever just like, oh, I'm gonna flush it, it's never a bad thing. Unless it's like clamped, and I have it clamped and closed to the patient, then that's a different story. What other questions? Okay, we're good with chest tubes?
Do you use the larger bore chest tubes?
I do.
You do?
Yeah.
Okay.
So I will use those, and the larger bore chest tubes, the benefit of that is you don't need to flush them. And obviously being larger diameter, I try to avoid them when possible. They're more painful for the patient. It creates a scar, and I'm not a surgeon by any means, so when I get the job done, but I don't know if I can make it look pretty. So I try to avoid them when I can, but if sometimes they're the quickest thing. So if someone is crashing and has a pneumo, or I say, the patient that has a tension pneumo, they need a chest tube, then I will say surgical chest tube. And by surgical chest tube, I mean the large bore with the tools that it sounds like the thoracic surgeon before me used. And that's the kind that I would use. Those are much faster for me to put in than this. But I can still, at the end of the day, I'll work with you, we'll work together. If someone's crashing, you bring me anything, a needle, anything, I can take care of it. So, yeah, but I will be using them from time to time. I'd say about, if I put in 100 chest tubes, 7 will be a surgery.
Okay.
So,
The carts will be stocked too for both options. Michaela and I and Meredith are gonna work on the carts, so the procedure cart, is that what we're calling it? Chest tube cart, procedure cart. Procedure cart, chest tube cart,
Yes.
whatever the name of it's gonna be, it will be ready for chest tube insertion.
other things, for procedures, Tony is probably gonna come over with me. with rounding and I get lost and she will be with me for majority of things. And that is, she's just another resource for you all. So if you all wanna do the procedure with me, she can help get things, or she can monitor your other patients for you. If you are busy with another patient and don't wanna do the procedure with me, she can do it as well. She's just here to be helpful. So anything you guys need, just let us know. Let's see, also I wanted, Kelsey Cave, our clinical pharmacist, is here. There are things that I want to go over with Mary Beth, Kelsey, as well as Dr. Payne, kind of already mentioned. So no changes yet, but just kind of in the back of my mind, things that, daily sedation vacations, I want to like look at the protocols and kind of see, but in general, so people know I'm aggressive to intubate early, and I'm also aggressive to extubate early. And I think our gentleman over in that room is a good indication of why I like to do that. So for extubation or intubation in general, and I'm gonna talk to the hospitalists and the residents as well. If you suspect that they're gonna need intubation within the next 24 hours, or I do, then I usually just go ahead and do it. I'd much prefer a controlled, calm, cool, collected environment. I, with all costs, try to avoid emergent, urgent intubations. And that can be not only, you have the physically difficult intubation, from my standpoint, where, we can cross that bridge when I can intubate with the bronchoscope as well. But those are more physical difficulties, but there's also biochemical difficult intubation. And so someone who we wait all day, like in this gentleman, where their bicarb is 10, that's not the ideal. I'd rather them a little bit more stable. But in general, I like to be a little more aggressive on intubating, but with that same token, I'm very aggressive with extubating. In general, the guidelines recommend a 15 to 20% extubation failure rate. So if someone is extubating a patient and 100 patients and 50% of the time they have to be reintubated, they're too aggressive. If they are extubating 100 patients and 5 of them are reintubated, they're not aggressive enough. So studies show that early off the ventilator improves outcomes for the patient overall. Everything from psychological all the way down to just physical body health. So I'm pretty usually aggressive. I like daily sedation vacations every single day on all vented patients. In general, where we stop sedation completely, try to wake them up. Now, if they get agitated, and these are the little nuances that we can come over together, but in general, when they start being agitated, I like to start sedation, restart it at half of what it was. And then you can titrate it. But less sedation, the COVID kind of changed a lot of things for the negative. There's a lot of good things that we learned, silver linings, everyone learned from COVID, but one of the negative things is too much sedation and too long on the ventilator. And that really has bad patient outcomes in the long term. So the other thing will be Levofed, weight-based dosing versus the way we use now. I'm a big proponent of weight-based dosing. And there's a few studies, there was one back in 2023 that we can go over, but in general, weight-based dosing has less total cumulative Levofed given over the course of time. I feel like it's more, you can titrate it a little more accurately. And then lastly, I just know it better. So when you tell me that someone's on 15 with Levofed, that doesn't mean anything to me. So I know I'll learn and I'm trying, but when you say 15 with Levofed, I don't know what that means. So weight-based dosing will be something else, and then any other policies or whatever, I'm here, I'm available. Lastly, I had a meeting with Dawn and some other nurses last week. I want to reiterate, I know this is on video, I will just say, I think there was someone before me who kind of did similar things that I'm going to be doing. I'm not him. I've never met that man. I'm not him, no. okay? I'm not gonna yell at you, I'm not gonna get frustrated, I'm not gonna, whatever. I'm usually a very approachable guy, calm. If I'm busy, I might, say I'm busy, but I will always be approachable and try to help you with whatever I can, okay? So if you have questions, just ask me.
It's on video, so don't yell.
Don't show it to that, whoever that was, but.
Oh,
I got a quick question. On the daily sedation vacation,
Yeah.
are we gonna go to soft restraints to kind of minimize self-extubations, or are we just gonna keep
I'll get
them?
with them.
so that has to be a case by case because that has to be a physician order. We cannot have
That's,
a
yeah, that's
protocol.
why I'm asking
Yeah.
if we're doing that, so, cause that, again, just that's what I was used to. This is the only facility that I've been to that doesn't use soft.
To be determined.
Okay.
I wanna talk about it with them first, but. Anything else? Was this helpful?
Yep.
Yes.
Does that kind of alleviate some apprehension?
Yes.
Okay.
On the BALs in the background that I've been taking care of that he doesn't, so if you guys send pleural fluid to the lab and you guys get a lot of pushback, if they keep calling you about any of the labs that he's ordering and it's 8 to 5 if I'm here, please just call me. That way you guys can focus on ICU patient care. It is a process. The lab is unsure about some of the labs he's wanting to run. We're working on it. But if they are just calling you nonstop, and you're like, I can't get anything done, please send it to me. I will take care of it for you guys. If it's night shift, they can store it until I can take care of it in the morning as well. So if it's a night shift issue and you guys are getting frustrated, please just tell them, like Kelly and I in the lab are working on it and we'll take care of it in the morning. So, the big thing on it is that they are wanting any cultures. Every BLA is gonna have a culture, chest tube probably also.
Yeah.
This is what they're wanting you to send it in, just this little 1 mil, they said just 1 mil fluid in this, and just send this down, and this is the culture for the pleural fluid. Other than that, the specimen cup with the blue lid, we'll just send 2 of those full from any procedure, if possible, if we can collect that much. But hopefully it all gets worked out. I'll keep Michaela and Mary Beth updated on it. There's just some confusion on how they're running it, where they're gonna send it out to right now. So we're working on it.
Another thing completely unrelated, but it popped into my head. If I'm not consulted on a patient, but you think I should be, let the attending know, or mainly the resident, early in the day. Cause I think, they're not really sure, the residents especially, I think the residents are kinda nervous, about everything, they don't know how to go through anything, or, anyway. So, just have the resident, tell the resident, like, I think Roten needs to be in on this case, tell your attending to call him, done, kind of thing. I think they need a little more direct, instead of maybe, and let's think about it for 5 hours.
I did get this, or we got this question last week too. Is every vent in the ICU gonna be a Dr. Roten consult? Not necessarily. Also, pulmonary critical care doctors. So you may even see consults on somebody who's not even on a vent. It's any ICU patient. I don't know if, anyways, there were some nurses that asked that last week, so it is any ICU patient he could potentially be consulted on, not every vent. It's up to whoever admitted hospitalist's main primary doctor. It's between that doctor and Dr. Roten.
Yeah, pulmonary and critical care, so not just lungs, also just general ICU stuff as well, so. Okay, alright, anything else? Alright, thank you all very much. I know this took out a lot of time and some of y'all wanna get on, so thank you.